Yeah? Is today your first one with criminal semester? Okay. Okay. Just as you get used to Davila and his drive. Okay, so the review, I should probably maybe take an hour. I'll be available. I had a lunch meeting I was going to do, but it got canceled. So if you have questions after, I'm available. Even this afternoon after ortho, probably till 4 if you have questions. Oh no, where's my clicker thing? Who is here? Was it Cola? Oh, there it is. I feel like she was accidentally. Okay, so the slides are on there. I didn't have the slides in my first class, but because a lot of us, I'm a writer, I'm a note taker versus auditory learner. They're on there if you need them. But again, nothing miraculous is on this review. It just kind of summarizes the topics that I've already spent a little more time on than others. But hopefully it's helpful. Okay, so the point of my questioning and why I asked them is, again, I've put more effort into it this semester with this exam so that it aligns with the PANCE. Okay, so what's the most appropriate diagnosis? Lab stuff, right? Lots of Endo labs, and how we tie those labs, or how we determine what labs we order. Physical exam, history taking is huge in Endo, right? I can't just say they have fatigue. I'm going to paint a picture. All the way to foundational scientific topics is a little pathophys. But when I do though, it's not very common, but those will be in there too. And then obviously interventions, medication, those things. So that should be not new to you, but again, Endo 6% of the PANCE. But this is a method behind my madness. Probably very similar to the questions that Dr. DeVore asks, right? Sometimes we ask patient education and those things too. Do you guys know, are there any first order questions on the PANCE? There are, but they all have like a 8-year-old male with blah, blah, blah. So I have to leave some of those quick first orders in there. Sometimes you overthink those the most, but so don't do that this time. But I still keep them short. But again, just go when it's a short question, look at what I'm asking. A lot of times it might be very straightforward and simple. Because guess what you guys have been studying all week for this, right? It's my first Friday test. Do you guys like those better, maybe? No. Okay. Anyway, I'm nervous about it, but you guys will be fine. But again, on the test, it's Endo, and we know it's going to be hard. Don't overthink it. You've been studying, if it seems straightforward, you have it, okay? Don't talk yourself out of the question. Obviously, read the question fully, avoid changing your answer, and then if you get stuck, go back to what normal is, right? If you're stuck, use your white piece of paper and draw it out. And when you draw it out, it'll be, ask yourself, okay, where's the problem? Is the problem the pituitary or the adrenals, the thyroid, that sort of stuff. So use that. You can even write on your paper before you hit enter on the password, right? And so I'll dump all of those feedbacks. If you struggle with, say, ADH, dump it on your scratch paper first. Okay. Here's a breakout of this. It shouldn't be a surprise. Thyroid was the biggest lecture, so most questions come from that. Intro was the smallest lecture. But with the intro one, I can tie some of those introductory topics into other lessons. But again, there's the breakout. Okay, so first lesson, we introduced negative feedback loop. Alterations to the endocrine system, that's that hyperfunction versus hypofunction. And is it primary or secondary, ectopic or resistance, right? And then there's a slide of terms that I've used throughout the block, from atrophy, hyperplasia, adenoma, neoplasm. All those things are fair game to like tie either into a question or maybe add to a question. But fairly straightforward, but just don't forget about it. Any questions on this? No negative feedback, all of that stuff. This one's pretty straightforward. What are hormone classes? So, look, they said polypeptide versus steroid or thyroid, that slide. You don't have to memorize it, but again, if I tie a question into this, and I ask you a polypeptide, don't pick steroid, right? It's in the name. If I ask you for a steroid or thyroid, you essentially just know thyroids and oh gosh, I can't say steroids. You don't have to memorize that whole thing. Okay. So posterior pituitary was a long time ago. What are the two hormones released by the posterior pituitary? ADH and oxytocin. What do I care about? ADH, right? Okay. So I think what did I say? 8, maybe 10% of the questions are on this one. And then just remembering that homeostasis, right? So ADH has to do obviously with baroreceptors, but I care more about osmoreceptors, right? So what triggers a release of ADH? Change in what? Serum? Yeah, osmolality, right? So the concentration of our blood triggers ADH. So if it is an increase in serum osmolality, pause real quick, what does that mean? Increase in serum osmolality. So that's sodium, right? Like sodium, glucose. Yeah, so it's more concentrated. Yeah, so what, if my blood gets more concentrated, what does my body do? Yeah, it increases it, right? Because ADH goes out, it goes down through the blood to the collecting duct, and what does it do? It pulls water in to reach homeostasis, right? So then again, that's that normal function. And luckily we only talked about 2 disorders, right? What are they? ADH, diabetes, and they're opposites. And not to oversimplify, you still need to study, but I'm going to give you a posterior pituitary question. What do I have to give you information about? Urine. Yeah, urine. And sodium too for SIADH, but urine. So the only time we really talk about urine is maybe with adrenal insufficiency. And there are some times where I talk about low sodium, but again, don't let like hyponatremia without urine deter you from what things. All right. So first one is SIADH. So it's that inappropriate secretion, right? This person is invited to the party, is not supposed to be there. Whether it's a CNS cause, a pulmonary infection, surgery, medications, or cancer, specifically lung cancer, they have this inappropriate excess ADH is causing a problem, right? What is that? So I just listed the common etiologies. Do I expect you to know all the meds? No, but it'll be the piece to the puzzle to get you to SIADH. What acute versus chronic? Why does that matter? Yeah, treatment, and then you want to identify, right, sick versus not sick. So chronic is more common, but that acute is less than 48 hours, so that's helpful thing. But we see chronic more often. And then if I have a patient with chronic SIADH, how do I know, who do I give 3% hypertonic saline to versus monitoring? That's severe, right? So they have neurologic symptoms, right? Neurologic versus asymptomatic. I'm here for my wellness labs and my sodium's low, okay? So you can see how the picture is different, and then knowing how to treat. For acute, we treat it fast. It's the only time we ever give someone sodium fast. But for the most part, we're going to do a slow hypertonic, right? We're giving them what they need because they have diluted serum osmolality due to excess ADH, so they're hyponatremic, and that's the reason why. Okay. Any questions about that? I'm going kind of fast, but labs are really important. What does this person's urine look like? I have excess ADH, so I'm pulling in extra water. I'm hyponatremic, right? So what does that urine look like? Yeah, super concentrated, right? So urine osmolality will tell you that. Specific gravity, urine output. You know how that's different than diabetes. Okay. 2 types of diabetes insipidus. What are they? Central, nephrogenic, right? So central is maybe they had surgery or something to disrupt the posterior pituitary process. Nephrogenic is less common. It's usually like a genetic thing, or say they're on meds, or they have like a genetic renal disease. Okay. What do their labs look like? Yeah, it's a lot. I'm peeing all the time. I'm thirsty all the time. But I may not come in because I'm drinking a lot. That's why I'm peeing, right? But then what happens? It keeps me up at night, and starting to interfere with my sleep. So that's how they present: polyuria, polydipsia, nocturia, lots of volume. How do we, for sure, confirm that they have DI? Some labs, yeah. What labs? So urine, right? What do I need to get diabetes insipidus? I need to confirm they have excess what? Excess urine, right? So you do that 24-hour urine, or inpatient, but you can do a urine output if you're tracking their urine. What does my urinalysis look like? Yeah, super dilute. So osmolality is a separate test, but specific gravity will show it says super dilute. You can do your osmolality. Am I going to be hyponatremic? No, I might be normonatremic or hypernatremic. I told you I wasn't going to test you on that. But remember, if I'm conscious and I'm drinking water, I'm maintaining homeostasis until I'm unconscious, and then I can't replenish the water, and then I become hypernatremic. Okay. These are very different, right? Let's see. So know the labs, etiology, presentation, all of that stuff. How do we, before we can decide if it's central nephrogenic, there's some tests we need to do. What is that test we do? Yeah, yes. So that's our first stimulation, or this one's a challenge test, right? So if I have a patient who I think has diabetes insipidus, I can't figure out if it's central nephrogenic from their history alone. I do this vasopressin challenge test, and I give it to them. I'm giving them ADH, right? I'm giving them ADH, and I notice a change in their urine. They're peeing less, they're less thirsty. What does that point to? Central, yeah, right? Because we gave them what they were missing. The pituitary was failing, we gave them what they're missing. You see how that points to where the problem is? And then how do we treat this? Especially with central. You don't need to know the nephrogenic treatment. Yeah, we give them well, first hydrate. Every single person needs to hydrate. Basic stuff, right? I think I had a picture of the water on that slide. I added that. So don't forget the basics, but then we're going to give them what they're missing. And so we can give them this. Questions on that? Okay. All right, so lesson 3 has a lot of slides. I was going to condense it, but I didn't end up doing that. But again, understanding normal, so going to our axis, right? So we did talk about the cross-reacting hormones, how when prolactin is in excess, it inhibits LH, how sometimes people with hypothyroidism will also present with high prolactin levels because of that thyroid-releasing hormone, right? So we talk about 2 of them just with prolactinuromas, and be able to recognize that. Let's see. You know what an adenoma is? Yeah, is it cancer? Not usually, right? They can be functioning and non-functioning. If they're small and non-functioning, you know they're there. Well, we start to know they're there when they're secreting it. I'm not going to talk about the cycle till 5, but again, it's ACTH triggered. Okay, is the problem. ACTH dependent. 90% of these are where? 90% of ACTH dependent excess. Where is it? Yeah, here. And the other 10% is where? Cancer somewhere, some tumor somewhere else. I say the lung to make it simplified, but it could be lung, pancreas, other places, right? What labs do we do? So I have a patient, so obviously this patient looks very different, right? What does this patient look like? There, where are my big? Potentially here, but a lot of, sorry guys, women tend to gain their weight in their hips, men tend to gain it in that Santa Claus belly, so not everybody with a little excess adipose tissue on their belly has Cushing's. What else?
Small limbs.
Yes. They look, think of that like ridiculous cartoon that I left in there. Perfect. So are they hypertensive or hypotensive? Hyper usually, pre-diabetic, metabolic syndrome, right? It takes a long time for these guys to get diagnosed. So, all right, so we identify what labs do we do. Before I ask, How does cortisol released in and ACTH released? Diurnal, right? So it's diurnal. So when does it peak?
Morning.
In the morning and then goes down, right? So okay, what labs do we order? Do we order cortisol? No, right? Because it's excess. Because of that diurnal, it's really hard. So what do? We need 2 out of 3 tests to be dexamethasone, 24-hour urine, and then the night salivary test. Perfect. So what does that tell me? Does that tell me this person has an adenoma? No, it just tells me they have high cortisol. High cortisolism, hypercortisolemia, just confirms that this is why they're presenting the way they are. And then we need to do the ACTH, and the ACTH will point us in the direction. This is dependent or independent, and I'll talk you guys through that in a couple slides. RADs make sense, we know we're looking here. Any questions? How do we treat these people? Simply, so I have this adenoma causing excess. Yeah, surgery, transcranial resection. Obviously, if it's a lung cancer, we're kicking them to oncology. They treat that. But we do our transcranial resection. I take out this adenoma that is causing havoc. What do I need to treat them with for at least 6 to 36 months? Steroids, right? Because we know now, like, it takes a long time for ACTH and cortisol to get to a normal level. So again, we need to do that. Last thing, what's an emergency related to hypopituitarism? Hypopituitarism, an emergency. Sheehan syndrome could be an emergency, right? The active duty guy who's had TBIs, he's like not doing well after. But anybody who has an adenoma is at risk for this. And let's say, what is it? Apoplexy, yes. Pituitary apoplexy. So there's a hemorrhage or necrosis, typically of someone who has an adenoma, and they present sick. Okay? So be able to recognize that, know the signs and symptoms, and what we do about it. That's all you have to know. Identify it from their signs and symptoms, and how do we treat it. Okay? What do you think? How do we do it? All the hormones are failing. What do I care about the most? Steroids, right? Because that could kill me first. They're not going to be like steroids, see you later. Like steroids are going to manage all the hormones, but recognizing that. Here's, in case you need it, going through this is something you can use of why we do dexamethasone versus just doing a cortisol lab when it's an excess. There's more examples in both, and then this obviously. Okay, any questions? All right. Lesson 4, what did I say, 30-ish%? 30. So most of the questions come from here, but this is probably we were most familiar with this maybe, and again, it's more what you're going to see out of all these conditions we talked about in this block. This is what you're going to see the most. Normal feedback, I hope you can't even forget this if you tried, right? You used it or learned it in AP. It was kind of my default one, but understanding what normal looks like. But specifically hypothyroidism, is it primary or secondary? It's the vast majority. Primary, right? There's a problem with the thyroid. I rarely talk about secondary. We started talking about labs and imaging related to the thyroid. What is my go-to lab? TSH. Yes, and I can throw in a T4. When do I order T3? Yeah, when would I order it? What? Hyper, yes, hyper. But what do we see most of the time on the phone? Hypo, right? Okay, yeah, so TSH all day. What imaging do I do? What imaging options do I have? Ultrasound, yep, radioactive, that radioactive iodine scan, right? Understand how those help, that scan helps differentiate between thyroiditis, cold and hot nodules, and graves, right? I'm not going to just give you the scan, but I might add the scan to help you get to your diagnosis. Okay. FNA. When do I do an FNA biopsy? Fine needle aspiration biopsy. Yeah, suspicious nodules, right? Yeah, perfect. Okay. Hypo versus hyper. They present very different. Yes. You know how they present. Think of the knob. Hypo, turning everything down. Hyper, turning everything up. Okay. Brady versus tachy. Tremor versus constipation versus diarrhea. Right? They're different. I can't just say they're tired. We talked, the labs first line, additional if indicated. Do I order antibodies on everybody that comes in? No. I might give you antibody stuff on the test, but I'm not going to expect you to, know which antibody goes to what and all that stuff. We don't need imaging to diagnose hypothyroidism or hyper, right? But we use it, especially if there's a nodule, like you guys already mentioned, maybe a goiter, or other risk factors. But again, this is diagnosed based on labs. With a hypothyroid, what does my TSH look like?
High.
It's high. With hyper, what is it? Low. And on all the subclinical things in real life, I won't put on there. What are special considerations? So who do I need to think about with maybe managing their thyroid a little differently? What populations? Pregnancy? Yep. And over 60 with cardiovascular disease, right? And so understanding cardiovascular and pregnancy and the endo. Pregnancy, I can send them into too, but understanding how you approach that and the education you do with that. Elderly, I don't think I have anything on apathetic. No questions on that. So I think that's more situational. If it wasn't, it is now. That's for the elderly hyperthyroid patient. What about children? Special considerations of children. Children can get hypothyroidism. There's hypothyroidism caused by Hashimoto's, and then there's that congenital one. Yes, cretinism. They look very differently, right? So don't be afraid if you see patients on your test, but know how they look very different. The pediatric one looks like a typical hypothyroidism with a few kid things. But how do we treat these people? Yeah, give them what they're missing, and then know the nuances to the treatment. Know a little bit based on the nuances for that. How do I treat somebody with hyper? Yeah, what's my definitive treatment? What do I do? What if I don't want an ablation?
Surgery. Well, you can get them that.
I don't want surgery.
You know meds for a couple of years.
Okay, meds. What meds?
Yeah,
there's a couple, right? When do I give PT? Maybe for typically, for pregnancy, because it's 3 times a day. I don't want to take that 3 times a day. So antithyroid meds. What else can help me in this hyper state? And all wound up.
Beta blocker.
Yes. Does that treat my thyroid? Or does it? No. Calm me down. What about when does prednisone come into play? Yeah. Does that mess with my hormones at all? No. I mean, it does, but it doesn't treat. It doesn't steroids. But it does. Does it treat my hyperthyroidism? No. Yeah. Okay. Feel good about that? Okay. Hypo. Let me make sure I don't have anything else. Talking about physical exams, they're different. Labs. What does T3 look like in hyper? Hyper. T3 and T4. What is it? How is the lab for Graves' patient different than someone with a thyroiditis? That T3 specifically. It's super high. So Graves is autoimmune. So Graves is an autoimmune disorder where there's this hyperfunction. So it lights up. And so T3 is high because it is hyperactive, right? With thyroiditis, remember, if you can go listen to the discussion, but thyroiditis, there's a passive, let's talk about it. Thyroiditis is a passive release of stored hormone. So they're hyper for a short period of time. And then the thyroid gland function is interrupted by a virus, by a bacteria, or by autoimmune condition. And so they go to low. So hyper, then hypo, and then some of them stay hypo and some get better. But from here, just be able to identify which one they have. They're very different. Which ones do I not care so much about? IgG4, the little old lady with the fibrous stuff. I mean, silent, probably not. It's really, yeah. But the other ones are pretty fair game because they stand out. They're very different. Painful subacute, when you get to it, I know you guys have ortho on your brains and you paid attention to lesson 5, but painful subacute versus infectious present very differently. Not only do they present differently, the treatment's different. So being able to tell those two apart and how we treat it. Autoimmune, what's the most common thyroiditis on this case? Hashimoto's, and which one's permanent? Hashimoto's, right? The rest typically improve. What about postpartum? Were they permanent or not? Not permanent, but what are they at risk for? Becoming permanent, and what? I have more babies, it comes back, right? So pay attention to those things. I went into detail in the class, I won't do it again, but if you have questions, let me know. Goiters. Really, goiters, and I'd like you to pay more attention to thyroid nodules. But what's the crazy goiter? So like kids in endemic areas, what's the problem for a goiter? Yeah, iodine deficiency, right? And they might have a big goiter, and then all of a sudden that goiter turns into a toxic multinodule. Understand that and how we treat it, okay? There were 2 different definitive treatments. Understand who gets what and how to recognize that. Thyroid nodules, it's very straightforward. You catch a nodule, what do I do first? I see a nodule, what do I do? Before I aspirate it, I'm just going to go in and aspirate it. What do I do first? I'm an endo. I do my physical exam. I feel a nodule. What do? Labs. And then from the labs, it tells me, do I need to do an ultrasound or an ultrasound and the radioactive uptake scan? Then we go to aspiration, maybe. So when would I aspirate it? If it's suspicious, I have to paint that picture to get you the aspiration, or I have to paint the picture that it's benign and we just observe. Okay, does that make sense? Sorry, I'm just like quick happy. All right, thyroid cancer. Don't go too much into this. I think it would overlap with the thyroid nodules. I thought it was a good question, but I changed it because it's very phase 2B. It was a good one, but I didn't do it. But thyroid cancer would probably correlate with nodules like that if you get them. They would potentially go together if I didn't replace, I took it out. I didn't replace that. What are thyroid emergencies? A storm is what's the problem? Excess, right? It's a storm. And what's the emergency for hypo? Right? Present very differently. Understand how their clinical picture. Obviously, the labs are pretty straightforward. But like, what caused this? What led me to this situation? Because they're really rare. They have a high mortality rate. People don't do good in these, but luckily they don't happen very often. But be able to identify that, and then what do we do about it? Let's do myxedema crisis. What do we do about that? Little lady, yeah, we're gonna have IV, yeah, levothyroxine rate, it's super low. What about thyroid storm? Yes, stepwise. This is stepwise treatment, and then know this stepwise treatment, okay? There's really only 2 stepwise treatments, but this is and they're both in emergency situations, with the VO and then this. Questions on that? Okay. All right. We're going to go through the axis together. So again, hypercortisolism, ACTH independent. So we did we got positive. We got back 2 out of the 3 initial labs. We ordered these labs based on this very Cushing's presentation. And we know they're hypercortisolism. I need ACTH to point me in the direction of where the problem is, okay? When I say ACTH independent, do I think the problem is in the brain or the lungs? No, it's either going to be in adrenals, or maybe they're taking a bunch of steroids, or their pain doc is giving them steroid injections and it's not showing up in our genesis or whatever. So first we rule out meds because that's the most common cause. But if it's not that, then the adrenals are misbehaving on their own. They're just either from an adenoma or hyperplasia, they're just kicking out excess cortisol. Pituitary is not to blame, essentially. Okay, it's independent of that ACTH pituitary. RADS, if I tell you it's either meds or adrenals, when you're thinking it's Cushing's syndrome, where do my RADS go? Yeah, the adrenals, yeah.
CT.
Yeah,
just that.
and we'll go through feedback loop in just a minute. I'm going to spend some time on this. But again, they present the same physical exam-wise, and those initial dexamethasone is also the same. But this is that summary thing that kind of like when you study and you go back to this, be able to explain why am I ordering a brain MRI? Why am I doing the whys behind it, and you should be good. Treatment, also in a nice little table. It should all make sense. I won't go into the medication for the bilateral adrenal hyperplasia, but it's on there. What other condition do we talk about adrenal hyperplasia and an adenoma? What other non-Cushing condition? Is it adrenal hormone? Aldosterone, yes. So remember the cortex is cortisol, androgens, and aldosterone. And then our pheo is what? The epinorepinephrine, right? And so don't get confused. So again, if there's an adenoma in the adrenals, it can spill out cortisol. It could also spill out aldosterone, okay? But they're going to present very differently, okay, on the test for sure. Maybe not in life. And same with adrenal hyperplasia. If my adrenals are bilaterally getting enlarged and working extra hard, it makes sense that aldosterone and cortisol would potentially go up. Does that make sense? So don't get them confused, but hopefully it makes sense why we see these in hyperaldosteronism and Cushing's syndrome. Okay, so you have 2 slides. This one is I left blank, so stay on this one. I'm going to go to the other one, and it's animation, since I can't get the smartboard to work, and I won't put you guys through me drawing, but I'm going to draw a little bit. 1 second. Okay, if you're all stuck on this feedback loop, this will be a helpful slide. No, I can't draw. Okay, I won't be drawing, but I think it'll still be okay. All right. So we have, I'm going to slow down. Okay. Where with ACTH, Cushing disease, where are the problems in Cushing disease? Dome, 90% of the time, dome, right? Okay, so there's our adenoma that's producing excess ACTH. And because of our lovely feedback loop, if ACTH is high, what else is high? Cortisol, and that's what we feel, and that's what we see. We're 10% of the time, if it's not a pituitary problem, where's the problem? In the lungs, right? Other places too, we're going to keep it nice and simple in the lungs. Okay, got it. There's our lung guy. Versus Cushing syndrome, where's the problem? Adrenals. Now remember, Cushing syndrome is the overall umbrella term for Cushing syndrome or Cushing disease, which is stupid, right? So you're going to break it down, ACTH dependent and ACTH independent. And again, Cushing syndrome indicates there's either an adrenal issue, an adenoma, bilateral hyperplasia, or they're taking an excess medicine. They're taking an excess prednisone. So we're going to talk about each case and how and correlate it to the feedback loop. All right, so signs and symptoms, we already know that. You guys got that down? You know what that looks like? And you know the labs that need it, right? Dexamethasone, the salivary test, and the 24-hour urine. So all that tells me right now is, this guy or girl has hypercortisolism, okay? Now, what do we do with the next thing? ACTH, okay? So, with ACTH, let's see, same. They present the exact same. The initial labs are the exact same. That's all I wanted to get with that one. Sorry. Okay. Okay. So, here's our adenoma. High ACTH equals high cortisol. We got that. That makes sense. Feedback loop, right? Ectopic, same thing. High ACTH equals high cortisol. So this is just the loop. Okay? That makes sense? Then prescription, I take a pill, I'm making cortisol go up, so what does ACTH do?
Or down.
It goes down, right? So low ACTH, we have a normal pituitary response indicating that the high cortisol is due to the prescription, right? It's the feedback loop. Right? Now we have adrenal triggered ACTH independent. I have an adenoma or hyperplasia. What do I expect ACTH to do? Low, right? Because the pituitary, it's not a pituitary problem, it's the adrenal. So again, this kind of helps you kind of bring back to where's the problem and use the labs to tell you where the problem is. Okay. We obviously have to catch it by our lovely person, our lovely features, right? So then, if I give you a patient who looks like this, you know which labs to do initially, and then you can tie it in. So what is, if I have a patient with, and they have hypercortisolism, and I tell you that, and then I tell you, oh, their ACTH is high, where do you think it is? Pituitary, most likely, right? Because it's because it's ACTH dependent, right? That high ACTH is causing it. Now, if the ACTH is low, where am I looking? In the adrenals, as long as they're not on the prescription. Does that help a little? I don't know.
Yeah.
Maybe. Draw it out. But again, it's trying to tie that feedback loop with the labs and then go back and forth. So like if you just look at the labs and you get stuck, use the labs and go back to the loop. Does that make sense? Okay. Sorry if you guys already know that, but hopefully it helps. And teach your dog this feedback loop. All right, so we talked about the opposite, adrenal insufficiency, right? What's the main cause of primary adrenal insufficiency?
Autoimmune.
Primary tells me it's the adrenals, right? And what is it? Autoimmune, right? Secondary adrenal insufficiency, where does that tell me what's going on? Yeah. Okay. So with someone with low cortisol, right, if it's in the name, insufficiency, how do they look? What do they present like?
Lost weight.
Yeah, lost weight. What else? What's their blood pressure?
Low.
Essentially hypo or orthostatic. What else? Skin. What does the skin look like?
Hyperpigmentation.
Yeah, hyperpigmentation in primary for sure, right? Because of the because as ACTH goes up to say, hey adrenals, we need you to work. They're unable to work because they're failing, but that increase in ACTH causes an increase of MSH. Okay. And then they get the melon. And their hands, their guns, and all of that. What labs do we do for primary adrenal insufficiency? What's the problem? Go back to the problem. Why am I here? I'm a patient with hyperpigmentation. I'm dizzy. I'm lightheaded. I'm losing weight. What's the problem? Cortisol is low. So what should we do? When should I check the cortisol? Why? Because it's diurnal, right? Yeah. And then you're going to do ACTH too. Okay. Secondary, the problem is up here. They present very similar, except what? They're not hyperpigmentation, right? They usually don't have electrolyte issues either. And then obviously the cause is secondary. I have to give you we'll do the feedback loops if you can't answer it yet, but like what, besides the clinical presentation alone, what will help me differentiate between secondary and primary? What else? What else? A lab. ACTH, right? The same thing that we use for Cushing points us in the right direction. For secondary adrenal insufficiency, probably my favorite slide is that first one where I have the sloth from Zootopia that goes slow. That one with the table, because that explains that, yes, secondary is usually maybe an interruption of the pituitary, but what else? I have a patient who's been on steroids. What's a condition that requires glucocorticoids? Chronic. What's a condition? Rheumatoid arthritis. So I have rheumatoid arthritis and I have steroids. What's the other one? What's a pole one? Pole one. we may give them inhaled, but I have an exacerbation, asthma. I have an asthma exacerbation, and man, when I take oral steroids, I feel good on them. So anyway, so you have someone with chronic steroids. That slide helps you explain while I'm on chronic steroids, and then my mom tells me those are bad for you, so I just stop. And then I present like secondary adrenal insufficiency, right? Because that graph, it takes a really long time. My adrenals are snoozing. My pituitary is like, oh, I get to work now. There's not enough cortisol in the body because I abruptly stopped my steroids, and it's a gradual process, okay? We'll come back to crisis. Don't let me forget, okay? This is that money slide. It was created. Again, it's that ACTH that points the direction, the electrolytes, the pigmentation. ACTH stimulation test is that we're giving them synthetic cosentropin and see what happens. And it's low in primary because adrenals don't work, right? They're autoimmune, failed. It's also, unfortunately, low in secondary because it takes me a long time for my adrenals to wake up. I've got to shake them, it's not working. It takes a long time for them to wake up. And sometimes they never fully wake up to a normal state. Okay, feedback loop time. Stay on this page. Okay. So don't get confused. It's the same feedback loop. ACTH tells the adrenals to produce cortisol, right? Okay, so same thing, but we're not going to get confused because why? They present very differently, one. And one's low cortisol, one's not. So the first one is what? Primary tells me it's a failure of the adrenals, right? They're hypo, they shrink down. The cortices are not working, right? It can be tuberculosis and everything, but I just care about autoimmunity. So these start failing. Oh, sorry, I had it on the wrong slide. I'm not surprised. Okay, what, if this is happening, what do you think ACTH does in response?
Drops.
Increases, right? High ACTH. It's a normal response. So it is telling me, we know that when adrenals fail, the normal response is for ACTH to go up, right? Because the problem is in the adrenals. Secondary, we suddenly stop our chronic glucocorticoids. Oh yeah, they're real bad. I'm not going to take these anymore. And then we have, so what will happen if I'm taking medication? What do I expect ACTH to do when I just stop? Yeah, because it's been low because we didn't need to produce cortisol ourselves, right? So it's low. It's a normal pituitary response to sudden loss, but ACTH returns gradually. It's gonna start to go up, but it just takes a while. It's napping, okay, or it was napping and now it's like, oh crap. And then hypopituitary axis damage, right? I had surgery or some kind of trauma, and I disrupt and something bad happens. This doesn't work. If the problem is due to pituitary failure, what do I expect ACTH to be?
Bottoms out 0.
Yeah, because it doesn't work, right? So it's low. It indicates a pituitary problem. So we take all this, and now how the hell do I apply it to clinic? Well, first I have to recognize that it's adrenal insufficiency. She looks nothing like our Cushing's person, right? So we recognize it from signs and symptoms. We get our labs, cortisol and ACTH. And ACTH, now you see ACTH is going to point you in the right direction. If you know what normally happens, that ACTH points you in the right direction. Did you get that? All I was going to draw were like arrows and excess hormone, but hopefully that makes sense. So again, if I give you a question of somebody that looks like this, and I tell you, you're like, oh, I got it. This is not a Cushing's patient. I think it's adrenal insufficiency, and I give you the ACTH, and I say it's high. Are you going to be able to go to primary? Yes. Yeah, you can't if you remember normal, okay? If you're stuck and you're like, oh crap, she told me the ACTH is high. What does that mean? And you go blank, It's okay. Inhale, exhale, and then draw your map. Okay, ACTH is high, but this patient is presenting like they have low cortisol. So is that response normal or not? If my cortisol is low, and then my pituitary is increasing ACTH, is that a normal response?
Yes.
Yes. Yes. And so that tells me the problem is the adrenals can't keep up. So it's Addison's, okay? Okay. Does that help? I'm trying to put it in like a question form. All right, no, we're going back to crisis. Maybe. Let's just go fast. Okay, what's their adrenal crisis or acute adrenal insufficiency? What does that person present like? Do I want them to come to me in primary care?
No.
No, or should they go?
Yeah.
Hopefully, yeah. Yeah, and so know what these people look like, right? They're definitely going to be sick. How do we treat them? They're like, hey, how do we treat them? Steroids, right? Yeah. How do I treat this primary adrenal insufficiency, Addison's or secondary adrenal insufficiency? How do I treat them? Steroids, right? Remember, there's certain caveats. If I'm going to be like, all right, here's your steroids. See you back in 3 months. Do I do that? But what else do we need to tell them? Stress, right? Because we lean back. When does cortisol go up? We need it to go up for an iPad test, or stress, or exercise, right? So fight or flight, all that. So how do we adjust? How do we account for that? We increase the dose if I'm sick. We need shingles vaccine. What if I'm in a car accident? What if I'm in a car accident or I have then what do I do?
Increase.
IV, yeah. We'll do our IV, our IM with an infusion. Okay, so more than just those 6 day protocols. Remember that again is that I give me steroids or watch me die type thing. Imaging for this is on this slide, and it should make sense. Oh no, I guess it's not. It's really just you would look at the adrenals. If you did a CT for primary, because you would look and they would be atrophied, right? You don't need imaging if it's meds. Okay. I'm close on time. Are you guys good? Can we push through without a break? Okay. I mean, we'll push through and be done. Like it's not a break, but then you're done. Okay, last lesson. Adrenal medulla. What is the feedback loop? Medulla. What is being released? Radical means epi and norepi, right? So this is our fight or flight. We have the nervous system triggering it. When does it's due to stress, right? So this is a good thing until it's not. When is it bad?
Too much.
A VO, when it's an excess. Do I want to walk around in fight or flight all the time? No. So I'm just saying with everything. Understand how this person presents. How do they present? It's hypertensive, headache, right? There was 4 things they talked about. There's other stuff too, but know how they present so you recognize this. Thankfully, this is it's called a zebra because it's super rare, but it's like, I'm not going to miss this, right? So what labs do we do? We're going to do a lot of labs probably, right? This person comes in. Well, what is that one good lab that we would tell them? Yeah, fraction 3 reference, right? So that's, sorry, I don't know if I'm talking loud enough. And then you can do a 24-hour urine sperm. What imaging do I do? I think it's a pheochromocytoma. Where's the pheo? It's in the adrenals, in that medulla, kicking out extra epinephrine. It's not as epinephrine, norepinephrine, not invited to the party, but this pheochromocytoma kicks them out. What's a consideration with that imaging? Yeah, not fun, right? What do these people, what triggers an episode? Stress, what else? What else? Day-to-day stuff triggers these episodes. Learn that. Be able to identify that's a trigger. That's a trigger. It could be constant, but usually they're episodic. That helps you kind of get to pheo. Okay, you guys know what labs to do, you know what imaging to do. How do we treat these people? And this, yeah, surgery. We're gonna get the hell of that thing out. We're gonna have all of our friends come to the OR and help, manage. Anesthesia is gonna be like really important. What do we, until they get to that surgery, what do we need to manage? Hypertension, right? And so how do we do it?
Beta blocker?
Why alpha? Yeah, A and C before B, right? You do a calcium channel blocker. We want to avoid that unopposed alpha constriction, the hypertensive crisis, so we need to do alpha blockers. Okay. I'm trying to figure out like why this is still like hit so hard, unless because mistakes happen. I don't know. And people get beta blockers and that's bad. Again. Questions on PS. I like that topic. It's like pretty straightforward. There's no ridiculous stimulation tests and all these things. It's very straightforward to me. Hopefully, you never see it. If you do, you know what to do. MENs, I have a table for that, so I'm going to come back to that in just a minute. What do we do with an incidentalloma, an adrenal incidentalloma? So we come in from the ER.
Check the size.
Yeah, check the size. What size matters in this one? 4. Yeah, if it's less than 4, and what? Not functioning. How do I tell if this thing's functioning? From the imaging or what? Labs. All the labs. Which labs? Not individually, but like which organs do it, or which pituitary primary organs are? What do I care about? Which kind of labs? Like what do I want to rule out? If I have an incidental finding on my adrenal, what could that cause? What diseases? Cushing syndrome. What else? I need to rule out some cortisol stuff. What else? What other hormone does the adrenal? Aldosterone. Yeah. Yeah, that is yeah, nephrins. Yes, so all the things we talked about in lesson 5. So cortisol, you don't have to memorize it, but just understand like, oh, if there's an incidental adenoma on the adrenals, this person feels fine. What labs do I need to do? Oh, we need pituitary and adrenal labs, right? For all the different hormones you now know. I just realized, I don't know if did I talk about, I skipped this, I apologize. Okay, we're gonna go back to 5 in just a second. So, MENs, here's this table. It is, all I'm gonna give you is one question, because there could be a question or two on the pan. I hate memorization stuff, so again, 2 and 3 have what in common? Medullary thyroid cancer. So, and a pheo, right? So, but 2 and 3 are very different, as 3 stands out. Why? Because of the 3 M's, right? 3M, I don't know. So, again, and then 1 and 4 are very similar. Parathyroid, pancreatic, pituitary adenomas, all of these things, but why is 4 different? Because of the cancer risk, right? So I'd have to tell you that. And I already gave you a sample of that on the test. I'm probably not going to test you on that one again, right? Okay, don't remember. I guess maybe that's like a cram the night before. Who would do that? No. Or you can have, if you have a better way to differentiate these, please share. My theory or my way is probably dumb, but it works for me. Okay. So hyperaldosteronism, right? So it's produced, it's a hormone naturally released from the cortex of the adrenals. What drives release of aldosterone? The primary driver. Is it ACTH or is it something else? The RAS, right? The renin-angiotensin aldosterone party. So it's in the name, hyperaldosterone. If aldosterone is high, and we know that it plays a role in electrolyte balance and blood pressure and all of these things, how does this person present? How do they present? Aldosterone is high. What would you catch before you did labs? To be like, something's up. Yes, hypertension. It is the most common hormonal cause for secondary hypertension. Okay, so aldosterone. You just have this guy who like understand for me, for life, for the test, what makes us somewhat just an essential hypertension stand out, right? Obviously the signs and symptoms, but what are other things? What are other things?
Sure, so
What is it?
I think it's unprovoked.
Yeah, or the labs hypokalemia. Yes, the labs for sure. It's only 30%, 7%. But yes, hypokalemia. I can for sure give you that. What else? Why would you, if I came to you, I'm now 43, 10 to 10, and I came and I have had high blood pressure for 5 years. Is that a concern? Female, yeah. So that's a concern, right? Females don't usually have hypertension in their 30s, right? What if, say, I'm 53 and I'm a male? Are you as concerned? No. So age and gender plays a role. What if I'm 50, what if I'm 43, I'm male, and I'm on 3 meds? That's, yeah, or refractory, as previously controlled. So remember, that's the end of this. Like, you can tie that into clinic and into cards and all that stuff. What is there's certain flags that be like, hey, something's, I don't think this is just the high blood pressure. Okay. So what are labs? If aldosterone's high, what are labs? We're gonna just do, they come in for high blood pressure, what labs do you do? CMP, right? Yeah, it gets my GFR, CBC, maybe, right? And so we already talked about hypokalemia. What else do I do? Yeah, ERA, what's that? Yeah, looking at the reading. So if aldosterone's high, what do we think renin's gonna do? Low, because it's not the problem, it's just adenoma's the problem, right? So we're gonna have low. And then what is aldosterone? If I check that, what does that do? Be high or low? Hey, yeah, it's okay, yay. Right, so high aldosterone, low PRA, potentially hypokalemia, okay? And again, it's not due to diuretic, it's due because this aldosterone, this adenoma, is producing excess aldosterone, causing the hypertension. This is a really big deal to treat, guys, because it just, people are going and being treated for essential hypertension, and this isn't catching. They're not getting catched, and they're having an increased risk for cardiovascular disease, heart failure, all sorts of things. What imaging do I do? Like when someone has an adrenal or hyperaldosteronism.
Thank you.
CT all day. There's no pituitary in this puzzle, right? Let's see. Talk about key factors. Identify what. I do a CT, and what 2 things could it be that causes this?
Adrenals.
Yeah, from causing excess. These adrenals. There's 2 problems that could cause excess aldosterone. We're at bilateral hyperplasia and an adenoma. Okay, and then knowing how to treat it is important too, right? Specific meds I've talked about, and someone had answered later. They had a question about spironolactone. I have that answer. Okay. If I have an adenoma versus hyperplasia, you're going to start with meds, right? Adenoma, try surgery first. We have meds too. And then, last but not least, what is congenital adrenal hyperplasia? There's classic and non-classic. So for this, I'm going to, you just need to at least recognize, know the labs or the underlying cause. So there's 3 things I can test you on this, right? But obviously recognizing it is first. What is it? So either I'm classic and I present at birth versus, and this is something just like thyroid that is screened for. But yeah, what do I, okay, we don't know what I look like, we don't know why I present, that's a fine thing. Okay, what hormone could it be? It's not aldosterone, it's not cortisol. 17 hydroprogesterone, it's androgens, right? So it's an androgen issue. And it's an enzyme, so there's an enzyme that's lacking. Does that help you? If I have an enzyme deficiency that can't get my body to make cortisol in my little flow sheet, does that help a little bit? So I am lacking a specific enzyme, which is 21, and I'm, yes, hydroxylase, and I have excess 17 hydroprogesterone. Don't worry, I won't be like 17 hydroprogesterone or 17 estradiol. I won't make that. I won't be 21 hydroxylase and 20. I won't do that. That would be horrible. But again, they're different. So just understanding classic versus non-classic. Classic is clitoromegaly, ambiguous genitalia, versus non-classic is they have enough of the enzyme, but they run into a problem around puberty or pre-puberty. I don't go dive into that too much. But don't forget it's on there, like I did. And I missed the whole slide. Questions? Okay. I will be available. Sorry, I went good 10 minutes, 20 minutes over, 15.